The current prevalence has been put at about 25% in the whole of sub-Saharan Africa. That is on the average, but of course you know that sub-Saharan Africa is big, so some countries it might be up to 30%, some it might be up to 35% or about that. One of them is genetics. It's been said that the black race are more predisposed to hypertension. The other thing again is access to medications. People in sub-Saharan Africa compared to Western Europe or to the North America who don't have as much access. So of course you can expect that the burden of hypertension will be higher in such societies. Of course, again, some people have linked this up also to stressful level. There's more westernization, there's more urbanization. People are adapting more to the Western lifestyle, taking more of the stored food, which is stored with salt. You know that the more salt, the more sodium, the more likely the blood pressure is going to increase. Yes. There is no country or no clinic in sub-Saharan Africa that doesn't have a sphygmomanometer that you could use to measure blood pressure. So the diagnosis, making diagnosis simple, is underdiagnosed. People just routinely could just go to a pharmacy or an hospital and you'll be surprised taking their blood pressure for the first time in the last 5-6 years, and they just find out that the blood pressure is high. We're just working on the roadmap because we want as many people to have access to measuring blood pressure, and that is why we are saying even in the common pharmacy, in the dispensary or the primary health care or places like that, there should be blood pressure measurement. That is what we can do, and that is the emphasis, and we are trying to push this into the African Union so that it will be adopted. You know, we don't have any large data to say this is the best medication for our patients, but really we extrapolate from African Americans. We want to look out for the best antihypertensive combination, 2-drug combination, in blacks residing in sub-Saharan Africa. Because in spite of the burden, in spite of the fact that hypertension is the commonest cause of heart failure, a great cause of kidney disease, great cause of stroke in our environment, we don't still know the best treatment. We are recruiting patients that are hypertensive and the blood pressure are not controlled on one medication. Yeah, and we have a blood pressure range for that. We don't want so we want a patient, it's just on one medication, that's monotherapy, and the blood pressure is not good. Secondly, we are recruiting newly diagnosed patients that have high blood pressure, provided the systolic blood pressure is less than 180. That is very, very important, because most times we find out that by the time it's more than 180, they need more than 2 drugs, and you are going to be using 2-drug combination. And then age 30 to 79. We don't want two patients that are too young, because we want to exclude secondary hypertension as much as possible. Yeah, neither do we want patients that are too old and might not be able to cope, you understand, with the stress of repeated or clinical trial being involved. Yes. 6 countries in sub-Saharan Africa and 10 sites. So we have Nigeria, we have Abuja, which is a coordinating center. Then we have Kano. Kano is in the northern part. Then we have Ibadan. Ibadan is in the southern part. So 3 sites. In South Africa, we coordinate the data management. We have 2 sites in Cape Town, University of Cape Town, and Pretoria. Then in Kenya, we have another 2 sites in Nairobi and Eldoret. Then in Uganda, in Kampala, we have a site. In Mozambique, we have a site in Maputo, and in Cameroon, we have a site in Douala. One of them is that the patients are going to have free ambulatory blood pressure monitoring, which, I mean, is not routinely done, as we know. Again, patients are going to have some investigations done, blood sugar, lipid profile, which are also not done routinely, you know. Sometimes patients have to pay for it if they don't have insurance coverage. So the most effect in reducing blood pressure, number 1, we have the least side effect profile, number 2, and we have the best effect on metabolic profile, like fasting blood sugar, fasting lipid, you understand, even on urea and creatinine level. So we're looking for the best 2-drug combinations. So I think it's unique actually. So it's going to be a unique set of data that we're going to be working on. Yeah.